Hello, everyone. You have joined the MSK low back pain for the Tier 2 cohort, and it will be led by by physiotherapist Sue Ellen Pereira and Senior Health and Wellbeing Coach Jiga here. I'll let you carry on.
Hello, good afternoon. My name is Sue Ellen. I work as a first contact physiotherapist in Barking and Dagenham, and I'm also an advanced physiotherapist. And I'll let G introduce herself.
Hi everyone, I'm G, the Health and Wellbeing Coach in this role for about 3 years now, and I'm supporting Sue in this webinar.
Perfect. I'd like to welcome all of you today, and I'm just going to share my screen. We do have a little bit of time for questions after, and if you could please put on your questions in the chat. We're happy to raise your hands. Yasmina will stop me and we'll take it from there. Just sharing the screen. Perfect. Okay. All right. So we're talking about a little bit about low back pain today and its management. So about 60% of the adult population will have low back pain at some point of time in their lifetime. We have a study which looks at most of adult age above 25 and over. They will, at least 28% of them will experience low back pain for about a month's time, which will kind of ease off a little bit after that. 1 in 4 people over the age of 80 years will have back pain. And there's one review that did a study from about 54 countries that says people will have low back pain for a little bit more than a day, which is about 11.9%. And if you're looking at a global scale of it, 1 month prevalence of low back pain lasting more than a day was for 23.3%. And it's most common in women above the age of 40 years old. And you'd have them more so in their 60s towards the older ages of life. Next screen. Next slide. Sorry, just bear with me.
You can click anywhere.
Yeah. The case study, we're looking at case studies today, okay? So this is your average case study that you would see of a patient coming in. Young, middle-aged adult has a week of low back pain. It either goes to the lower back, radiating to one of the 2 buttocks. In this case, it is the left buttock. Pain is sudden, doesn't realize how the pain has come in. She would probably do any type of job, mostly maybe doing something like a cleaner, or maybe she has a desk job. But the important part to look at is that the pain is coming on suddenly, and it's been there for a short period of time. Now, she would complain that she has pain with all movements, and she mentions that she's finding it difficult to bend and lift something. And she's very unsure of what caused the pain, can't remember anything in particular, but mentions that she could have lifted something heavy, she could have picked up something from the floor, and the pain is on a very severe scale. The next thing that we're thinking of diagnosis for this patient is 90 to 95% of the cases that come in for low back pain in the acute stage is a non-specific low back pain. What I mean by non-specific low back pain is that it could be related to a muscle, mostly a muscle spasm. It could be related to a muscle that is irritating the nerve a little bit, that's coming into the buttock. And we have risk factors for this. The risk factors for this is mainly physical inactivity. What I mean by that is I don't mean a sedentary lifestyle. I mean that they're not actually engaging in exercises. It could be obesity. It could be heavy lifting, if they're lifting something, or even repeated lifting. It doesn't have to be heavy lifting, but it could be repeated lifting, which is about 5 kgs or so, stress, and of course, depression. When we look at low back pain, we also need to rule out, of course, the differential diagnosis. It could be non-specific, which is the 90% of it, or it could be the other. Okay, we're looking at neurological causes, which is either sciatica, myelopathy, neuropathies, deep gluteal syndrome, spinal stenosis. Then, of course, you have your systemic causes, which is sacroiliitis, ankylosing spondylitis, vascular claudication. And then, of course, we have the other, which is very specific to localized back pain, which would be an abdominal aorta aneurysm and aseptic necrosis of the femoral head, facet joint arthropathy, greater trochanteric pain syndrome, which is your hip type of pain, cholectitis, peptic ulcers, pancreatitis, renal causes, prostatitis, which is acute, pelvic inflammatory disease, osteoarthritis of the spine, osteoporosis, polymyalgia rheumatica, rheumatoid arthritis, and the last but not the least is shingles. Again, perfect. I'm just going to the next slide. Perfect. Now we're going into management of it. The first thing is that we need to rule out any serious underlying cause. So you need to rule out, of course, your CES, which is your quad equina syndrome. You would rule out any fracture, any cancers, any other serious underlying causes. The main advice that you would give them is, of course, the use of hot water bottles and cold pack to just relax that muscle spasm at the lower back, to relax those muscles in the lower back. You're going to then reassure them that it's unlikely to be any serious structural cause. And of course, to return to activity, keeping them active, doing their normal everyday activities. Discourage them from bed rest for too long, because that can cause stiffening of the muscles that you would have in the lower back. Of course, you would have gradual return to work, and you'd give them some self-management home exercises. Normally, the recovery time for low back pain is within a couple of weeks, say about 6 weeks, 6 to 8 weeks for most people. Now, what I put here is exercises for acute low back pain, which I think is important that we teach to our patients in terms of the non-specific low back pain. So the first thing that we're going to look at is, of course, pelvic tilt, where it's a gentle roll of the abdomen front and back. What this is going to do is it's going to release those muscles of the lower back, which is that stiffening that they feel, and that generalized localized pain that is across the lower back. And this will help them, especially if they have long sitting hours, or if they're standing for too long. You can ask them to do this in either sitting or standing, and you'd ask them to roll their pelvis front and back. The next exercise that you would give them is a clam exercise. You could have them lying flat on their back. It doesn't have to be on the floor. It could be on a bed. You could have them flat on the back or on their side. Okay. What they're slowly going to do is they're going to slowly lift their hip up and down. And of course, turn on the other side and lift up and down. This is going to engage the core muscles, giving an inhibitory response to the muscles of the lower back, causing it to go into relaxation. Okay, this will also help strengthen the hip muscles on the outside of the hip, which normally go again into a spasm with that low back pain. I have attached video links for this, so you can either watch this a little bit later in depth, or you can even share this with your patient. That's absolutely fine. The next thing that we're going to go to is 2 other exercises, which is knee to chest and hamstring stretch. Okay. With the knee to the chest, if the patient is having pain with bending forward, I would tend to avoid this because this might aggravate symptoms. However, if the patient is not restricted in bending forward, but there's just pain going forward, I'm happy to continue with this exercise. The way this exercise is done is that you just lift up the leg up as much as possible. It doesn't have to be all the way to the chest. And you'd feel that nice bit of stretch underneath the buttock muscle on the leg that is lifted. Okay, this will stretch out the gluteal muscle a little bit more, again, releasing that spasm, that tension on the lower back. Okay. The next exercise that we're going to do over here is a hamstring stretch. Okay, this is very good for people who are sitting for a long time or who are standing for a long time, because those hamstring muscles just go into a little bit of tightness because they are longer, larger muscles. So as soon as the gluteal muscles of the lower back go into a spasm, these are the muscles that normally overwork, which is why you will also have people sometimes complain of pain coming into the buttock region and into the back of the leg. It is that hamstring muscle that go into tightness, which will give you that pain that comes down to the back of the buttock and into the leg as well. So with this, you would advise the patient to pull a towel or even put their hands behind the back of their thigh, pulling their knee closer to them. Now the knee could be at a 90-degree angle. And then what you're going to do is you're going to advise the patient to slowly lift the foot up and point it towards the ceiling. Now, most people are not going to be able to get it all the way up, and that's absolutely okay. They should just take it up to where they feel a light stretch. Again, here I've placed YouTube links in the corner, so y'all can have a look at the exercises as well later. The next thing that we're going to look at is chronic low back pain and its management. Again, I've put a case here, which you're most likely to, again, see in practice. Middle-aged male working in construction has had low back pain with intermittent pain into the leg that comes down into the foot. Normally, I would call this a sciatica. The pain feels like a sharp pain. Sometimes complains of pins and needles in the leg. Now, the pain can be ongoing for more than 3 years. And the patient has periods where there's no pain, and sometimes it's a flare-up of pain, normally related to activity. And this patient has been waiting for physio and coming back into y'all again to ask for medication, so to speak, to deal with pain management. Now, of course, this patient has a moderate to high level of pain. It varies with activity, and there would be intervals where there would be higher periods of pain as compared to the other. Now, with this chronic low back pain, the first thing to consider is an alternative diagnosis. If the patient has had a pain for so long, either the symptoms could be progressing slowly. It could be something as a neuropathy from another nerve, not just the sciatica. It could be, you could rule out cancer, you could rule out a hip pathology, and you could rule out even sacroiliac joint pain. So consider alternate diagnosis for low back chronic pain. Consider the stress levels of the patient, consider the mental health of the patient, because all of these things would affect chronic low back pain as well. Of course, we'd always rule out red flags. And then you'd consider imaging. You'd consider imaging to check if the pain and the clinical symptoms have basically differed from the structural prognosis and the structural changes that you would see on your imaging. Management for this, again, you're going to look at exercises. Now, the exercises for chronic low back pain is a little bit more different because you're going to work not on flexibility and opening up of the muscles, but you're going to look at engagement of muscles. You're going to look at engagement of muscles because most likely this patient would be so busy with work that they don't have any time to exercise. You're mostly going to see people who have very active lifestyles, but have little or no time to actually sit and do activities that would work on engagement of their core. So the exercises that you give over here is to engage the core. The first one you do is hip twist. Very simple again, you'd be lying flat on your back, okay? And you drop your hip out to the side and bring it back in again to the midline. While you're doing this, what this does, it works on the pelvic floor, it works on the hip muscles of the side, and that contract and relax of the hip muscles, engaging the pelvic floor will cause that engagement of the core, okay? This works very well with also hip pain and also sacroiliac pain. The next exercise that you would consider is hip abduction, okay? Hip adduction, sorry. You can do this again in either sitting, you can do it in chair sitting, or you can do it lying flat, okay? You're going to place a towel or a pillow between your knees, and you're going to squeeze with the inner thighs onto the ball, onto the pillow, okay? And breathe normally to it. Again, all of these exercises don't need to be done on the floor. They can be done in the bed, wherever the patient feels comfortable. This exercise is going to engage, again, that pelvic floor, the core muscles, okay? And it's also going to work the diaphragm muscles because you're going to talk, they're going to count loudly, and they're going to breathe normally through this exercise. While you're working on the squeezing of the ball, this causes again a contract relax with the muscles of the lower back, relaxing those lower back muscles. The next exercise that, of course, you would consider is a straight leg raise. This would be, I would say, avoid this if the patient has pain that comes down into the leg, into the foot. If the pain is still coming into the leg, that's absolutely fine. However, if the pain comes into the foot, I would avoid this one because it could irritate the nerve for the first couple of days. It will ease out a little later, but it would aggravate the pain for the first couple of days with the patient, causing the patient to get a little scared. So use this one with caution, but this is definitely good for when the patient is coming to you after in 2 or 3 weeks of that chronic pain flare-up. This is a very good exercise to engage the core long term. It's a very good strengthening exercise. You just lift the leg up to the count of 5 and slowly bring the leg down. This will engage the lower abdominal muscles and work on the strengthening of that lower abdominal core contraction. The next exercise that you would do is very simple hip bend. You could again do this in lying down, and you could also do this in sitting. And what you do is you drag the foot up all the way up to the midline, about 90 degrees of your chest, and slowly bring the leg back down. This again will engage the lower core muscles. Now, these two exercises, if you're feeling that the patient is finding it very difficult to do this, you could ask the patient to do this in standing. So this would also help engage the core muscle, the lower abdominal core muscles. And it's very simple, very light, and also mimicking normal movements like walking and standing, which will get the patient to kind of be a little bit more active as well. So if the patient is finding this difficult in lying down, please feel free to make the patient do this in standing. This will help strengthen those core muscles again. Of course, if exercises don't work for the patient, you would refer to the musculoskeletal team. Now, the musculoskeletal team will offer physiotherapy. There is a pain management referral that you could do where they would have psychological therapy. You could refer them to talking therapies. They would also have radio frequency denervation, whereas the nerve that comes into the leg that is irritated would be burnt off. And of course, an epidural where a steroid injection would be injected into the nerve, thus allowing the patient to move a little bit more freely without the pain that comes into the leg. Last but not the least is an orthopedic referral, where the patient would be referred for a spinal decompression. We come to the end of our slides. Any questions for me?
There are none so far, but I would urge any of the participants, attendees, to ask any questions if they wish. Shall we maybe stop sharing,
Yep.
So Ellen, just so I can see if there's any hands raised up?
Perfect.
Thank you. In any case, if you can't think of questions now, then please do put them in the chat. Shall we proceed?
Yeah. Sure.
Yeah. Okay.
Sorry, G, I'm gonna just answer this question if you don't mind.
That's fine.
The question is, can all the exercises be done on the bed? Yes, all the exercises can safely be done on the bed. I would prefer they do it on the bed because they would find it a lot more easier to do. So yes, all the exercises can be done on bed.
Thank you very much.
Thank
Would it
you.
be okay to move on?
Yes, I'll let you
Yeah.
take over now.
Okay, great.
Thanks, Sue Ellen, for that. So I'm going to share how the personalised care team can actually support in the management of pain. And this is a non-clinical kind of support to facilitate patients who are referred for pain management. Moving on to the next slide. Thank you. So how many of you can relate to pain? Be that physical, the pain in the neck, in our wrists from working the keyboard all day, referred pain into the elbow, you know, the lower back from sitting too long. I know my glutes always get quite upset by sitting all day. So these are common kind of issues with pain, that they nag us. They're constantly there and we'll try and ignore them. But more than that, pain can also, there are other factors that we need to consider with pain, such as change of our mood. So our mood changes, our energy level changes, how it impacts our mental health and our mental well-being. And also, one thing that's quite common is that we'll reach out for comfort food, because what we're trying to do is pacify the pain by treating ourselves and making ourselves feel there. That'll make us feel better. But actually, this is just adding to the whole picture of lower back pain or joint pain in general and pain in general. Next slide, please. So Sue has already touched on some statistics, but I just wanted to really bring this to life, that there are about 20 million people, that's a third of the UK population, that live with musculoskeletal conditions. So it's very common. And here, the stats for 2013-2014 is suggesting it's the largest area of the NHS spending, with over 5 billion. I think it's more than that now. More than that, it's the amount of days that people actually take off sick. So the cost of sickness is escalating. So what can we do? 1 in 3 GP consultations are actually related to musculoskeletal pain. So physiotherapists are quite busy, as are pain management coaches. What can we do? What can we do to prevent the deterioration or this pain from overtaking us? Next slide, please. So the most common pain areas, you may all be aware of this, is the neck, so 53%, the lower back, 63%, and Many of you will already know that the lower back pain can also be referred to neck pain, because what we're trying to do is shift away from the lower back pain and it's ending up in our neck. So it can be it can be referred. Shoulder pain, 38%, and wrist pain, 33%. And this is all thanks to our digital working lifestyle that we are now engaging with. And we know that long-term musculoskeletal conditions can end up with things like arthritis, which is a growing area of chronic disease, of long-term conditions. Next slide, please. So when a patient is actually referred to the personalised care team, we will take into consideration everything that I've just pointed out. So the social prescribers are great at signposting patients or attending to their needs when it comes to environmental needs. So what environmental changes need to be made to support this patient get active again, to become more mobile again. They may also refer them to pain clinics or community resources that may help them recover from pain. Everything is really to improve the quality of life of patients, and it is about asking them about what makes the pain worse, what makes it better, and what they feel will support them in their recovery. Care coordinators are great at care navigation, especially when it comes to pain management clinics, because sometimes with long-term conditions, they have multiple other cofactors existing with pain. And health coaches, many of us are really obviously experts in supporting self-management, but also for pain management, especially persistent pain management without causation. So this is kind of like the emotional imprints that end up in our muscles and in our joints, preventing flexibility, or it could just be the fact that we're sedentary for most of the day. And so we then begin to uncover what this pain is and how we can manage it through coaching with compassion. Next slide, please. So here I'm just sharing some early intervention coaching for pain management. So this is health coaching for people with persistent pain. And really, we know that this is a program that's run by Peak Health Coaching that I'm just sharing with everyone. It's these are short-term solutions that often cause more harm than good in the long term. So things like, if I just talk about the NICE guidelines, it doesn't really recommend that an individual should start pain medications immediately for primary management of chronic pain. And sometimes talking therapies, coaching through that pain, what it looks like, how it feels, how we can uncover it, and what things can make it better. So movement, as Sue Ellen just mentioned, movement is essential to guide them through some movement to overcome this pain, because pain pushes an individual into a freeze response. They're stuck in fear. So how can we uncover their fear? How can we get them out of fear so that they become confident in moving again and know that actually I can manage this pain and I don't need any medication to do it? So these are the kind of conversations we would have as health coaches. So pain management coaching is evidence-based approach to persistent pain recovery, and it really is engaging with self-management, encouraging that patient, giving them hope, empowering them, motivating them, and building the confidence to know what to do. And often this is a multidisciplinary approach with a physiotherapist, with pain management clinics. So we work in tandem. Next slide, please. And here's just an example of what I do with my patients. So I listen to their pain story because we have time to do that. As you know, health and wellbeing coaches, social prescribers, we can dedicate more time to our clients. So we uncover how they got there. We allow them the time and the space to talk about their pain, what makes it better, what makes it worse. And often you'll find that they will figure it out themselves. They'll have an aha moment in that conversation, and they'll come up with their own solution. And all they need is that, well done. That's amazing, and motivating them to take the next action. And what would that look like? Self-management is the key. So it's supporting people to find their ability to respond to their long-term condition. So what are they already doing that's working well? If it's not working well, what's changed? Have they made any lifestyle changes? Have they changed their car? Does their mattress need changing? So we look at all sorts of different things. And then the consultations we provide is also about control. It's a very realistic picture, trying to kind of like guide their expectations, and it's not a cure. So a lot of things I do is about practicing good posture, and it's very simple to do, and a lot of us don't do it. So the first thing I will always do when a patient walks in is just look at their posture. And when they're sitting, how are they actually sitting? Are their shoulders falling forward? Are they hunching? Where is the tension sitting in their body? And we know that this is a freeze response because you're trying to manage the pain within, on their physical body, in their bones or their joints, wherever it's sitting. And a lot of the time, it's also sitting in their mind. They are just frozen in that time capsule when that pain happened. And once we start to unpick it, you'll find that their body language completely changes. I teach a lot of functional movement. That's with awareness. So bringing patients aware to how they're moving and walking and sitting. And that's a real revelation for a lot of people. Other traditional remedies that as a health coach I will discuss, as a nutritionist also, is the traditional remedies, Epsom bath salts. These are things that we've known for years and years, decades. And so I'll just bring that to the forefront. The Epsom bath salts is a great way, sitting in the bathtub. They can't sit in a bathtub, then a foot soak is fine, or a hand soak is just as sufficient. And nutrition, just pointing out, and this is from the Royal Osteoporosis Society, are they taking vitamin D3? Because that's essential for the maintenance and the health of their bones and joints. The omega fatty acids, so things like oily fish or flaxseed. And then also MSM, which is a naturally occurring organosulfur, and it plays an important role in the production of collagen and glucosamine. Actually, a lot of research has been done in racehorses that have come to the end of their lifespan, and this is where the research started, actually, before it came into arthritic pain, managing arthritic pain, so on and so forth. So please take a look at that. Next slide, please. And here's a brilliant resource. It's called Flipping Pain, and it really has some great tips and understanding about pain. So there's some movies on there, there's some clips, there's some real life stories, resources, and you can even meet an online team just to have a soundboard, someone to talk to if they can't get out and about. So if they're isolated at home, brilliant resource, highly recommend it. Next slide, please. So I'm going to share a lived example of navigating pain, and this is my own personal example. So it's the first time I'm sharing it, so please bear with me. And this is why I'm passionate about postural well-being, the prevention of it. Not a lot of people know this, but I was actually born with a congenital dislocated hip and spent most of my childhood, so 8 years, in and out of extensive surgery. The acetabulum hadn't developed properly, and so the femur would keep slipping out. And so this was diagnosed at about 11 months. So many surgeries. You can see from the x-ray the condition of my hip. and also lived with a gait. So that's a defective hip abductor mechanism, which for 30 years of my life, I was living with a gait. This also created scoliosis in the spine. So you can imagine the type of pain that I have probably managed over those years, and all non-medicalized. So I stepped into, after completing my medical degree way back in the 90s, I decided to look at naturopathy and other forms of rehabilitation that could support me in my own rehabilitation and prevention of deterioration of joints and what have you. In my early 30s, I ended up with vitamin D deficiency, which I had no idea of because there's no training on this. So that was a learning curve. And then osteoarthritis in the early 30s, which was grade 4 at that time. So really debilitating pain. However, I managed it through the functional yoga techniques that I'm very passionate about teaching. And these are all adapted to seated work. And they're on par with the physiotherapy and some osteopathy kind of techniques. But a lot of it is engaging the breath. So I'm a big believer in coherent breathing techniques because it's worked for me. Not only has it worked for me, it's worked for a lot of the clients that I see because I just put them in the zone of breath work. It takes them out of the pain and just distracts them. So it's a distracting technique, but 20 minutes of coherent breathing will actually start working on the neurological patterns in the body. So there's a lot of scientific evidence behind this. And 2014, I ended up with a total hip replacement. So I managed osteoarthritis for 10 years using the functional yoga techniques, the breath work, and what have you. And that was pain-free. So I'm speaking from experience, that hence the passion behind it. My rehabilitation took the form of hydrotherapy. So it's something I highly recommend for patients. It's a shame that we don't have many hydrotherapy units because I do refer patients to hydrotherapy, but I know in East London, Northeast London, there's very few. And if there are some, they're oversubscribed. Same with Northwest London with Stanmore, Hospital. Acupuncture is another one. If patients would like to try it, I do, especially those with private medical health. I will signpost them to acupuncture. It's great for pain management. There's a lot of scientific evidence behind that. And in fact, that supported me through my hip operation, hip surgery, and functional movement. Next slide, please. So preserving the lifespan of our joints. Prevention is better than cure. What are you actually doing right now in your working life to prevent deterioration? And this is something I've been doing, whether you're driving a car, whether you're sitting at your office desk, we can do this. And one of the easiest way of doing it, so we're just going to do a little bit of a practicum, I think. So if we just sit in our seat, wherever you are, just make sure that the chair you're sitting on, if it's got wheels on it, it doesn't push away. So be safe wherever you are. I'm just going to ask you to hug your elbows into your ribs and face the palm of your hands up towards the ceiling. So you're hugging the ribs in, your arms are extended out, and your palms of your hands are towards the ceiling. And all we're going to do is turn our elbows out to the side. So you're still hugging in the elbows and you're turning your hands to the side and bring it back in towards the midline. And just tune into what it's doing for your spine. So this is a really easy spine extension and flexion. So simple to do. And I usually kind of like speak to patients and just say, imagine you're holding pizzas and it's the most delicious pizza and you're not going to drop it. So what we're going to do is extend our hands out. We're still holding the pizzas. And then we're going to draw the hands in towards the inseam and turn the hands around. And so this is such an easy technique to teach clients or patients or do ourselves whilst we're sitting at the desk. It just releases the tension from our shoulders and the spine from sitting too long. Many of you might have already practiced the sit bone technique that I use, which is what we're going to do is just turn the flesh of our thigh towards the midstream. So the left thigh, pick the flesh and turn it inwards, almost as though you're wringing the muscles. So you're releasing any tension in the muscles. So you're going to do that on both the thighs. And then you're going to grab the skin of your buttocks, your glutes, and you're going to lift them back. So you're peeling the skin backwards. Okay. And what does that do? It actually releases the spine. For the first time, you're actually noticing or discovering your sit bones, and you're not sitting on your sacrum anymore. And it's a very easy way to have neutral spine so that the bones are stacked and healthy. Now just raise your arms up above your head, clasp your hands together, and give yourself a stretch. So you're grounding your feet. So push your feet into the ground as you're lifting your arms up above your head. Brilliant. And just releasing the arms on either side, shrugging the shoulders up, turning them round. And an easy, if you're end up with a tight groin, a very easy technique to do is whilst you're sitting in your chair, come to the edge of the chair. So keep your right buttock seated on the edge of the chair and drop the left hip off of the side. So you're just literally dropping the left hip, bending the left knee. So it's almost as though the knee may be touching the floor, and you're just going to allow gravity to do the rest. So you're going to breathe in, maybe hold the seat, the chair, the arm of the chair to support you. Keep your right foot grounded and allow gravity to open up that hip, the left hip. And the more you breathe into it, the more you'll release the tension in and around the groin and releasing the hip. So we can do this whilst we're at our desk, and you can repeat that on the other side. Very, very effective way of managing pain and just to preserve the lifespan of our joints. And I've put some strategies there which Sue Ellen's already discussed. So, but please do consider complementary therapies such as relaxation techniques, mindfulness, Tai Chi, Pilates. These are all beneficial to help the body mobilize, especially when we're feeling pain. Next slide, please. There are a lot of functional movement techniques that I have on my website. I run functional movement as medicine. Been doing this for the BAD, the British Association of Dermatologists, for several years now, which is quite beneficial to a lot of people. And I've put the physical activity pyramid there just for us to take some reflective time for ourselves as healthcare professionals to tune into where are we on that pyramid. Are we quite active? Do we have daily activities that we can get away to? Or are we at the top of that pyramid, which is actually we're spending a lot of time working and not enough time mobilizing our frame, our physical frame, and our mental health, right? Because it's connected. The body and mind are connected. So please, please, please do take some time out for your own well-being. Next slide, please. And here are some testimonials over the years that clients have fed back. So I hope you've enjoyed that, and please do connect with your health coaches and your personalised care team to see how they can support you, support your patients, manage pain. Thank you.
Thank you very much, G. Thank you very much, Sue Ellen. Please, everybody, if you do have any questions, This is the time. We have a little bit of time before the end. Could I ask that you take a moment to fill in a survey that I've prepared so that we can see what you thought of the webinar? Please do give us your feedback. Most of it is multiple choice. Please feel free to put in any further comments at the end. Otherwise, it's just multiple choice. It'll be very quick. And upon completion of this survey, you will get a certificate of attendance. So I'll put it now. It is now on chat. Any more questions? I have a question actually for you, G, and Sue Ellen. Just wanted to know. I do have lower back problems, and I think you may have mentioned this, Sue Ellen, at the beginning, but I do wonder sometimes when I do start having the back problems if it's better that I don't do things, for example, like vinyasa yoga, or if it's better that I actually do continue to do a little bit of movement. What's your take?
So personally, for me, I would say activity is better than no activity, because although it might aggravate your back for some parts of the time, what it is actually doing over a long period of time is actually strengthening those muscles, keeping those core fit. And even if the pain is not going away, as long as it's not getting worse, it's a good sign.
Okay. That's great.
My advice would be the same, actually, Yasmina, but instead of doing the vinyasa, perhaps move into the yin yoga and with Pilates. So look for yoga and Pilates so that you can strengthen your core and learn how to reprogram those muscles so that you've got good core balance before you go back into vinyasa. So I would give you about 3 to 6 months. Try that, or just Pilates itself, and then move back into it, because that will teach you how to work those muscles better.
Okay, wonderful. Thank you. And actually, we do have another question from Moya Yuma. I hope I'm pronouncing that right in the chat. Is swimming a good fitness?
Yeah.
Yes. Anything in water for muscle or bone health. Water, hydrotherapy, water activities are incredible. So yes, highly recommend that.
Please, could we have some more answers? I've already gotten so far about 4 or 5. That would be wonderful if you could just take 10 seconds. The only thing you have to write down is your name, I promise. If you all you have to do afterwards is select. I will stop recording.